Welcome to the Johns Hopkins Medicine online webinar series. Today, Dr. Alex Johnson and Dr. John Thompson will be speaking about common sports and activity-related injuries, what to consider from pain and breaks. Before we get started, we'd like to provide tips so that you're comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenters. The last 30 minutes will be dedicated to our live Q&A session. Please note this program is being recorded. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note if you do not want your name attached to your question, please check send anonymously. Also, your email address will not be shared with any third parties. We will do our best to answer all questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. And now I would like to welcome Dr. Alex Johnson and Dr. John Thompson to begin our presentation.
Thank you, Amy. So I'm Alex Johnson, and I have John Thompson here with me as well, and we're going to be talking about sports and ankle-related injuries. So my portion is talking about common sports-related injuries, mainly related to the shoulder and the knee today. So I have no disclosures related to this talk. I have no relations related to products related to this talk. So just a little bit about me. I did my medical school at Emory University in Atlanta. Then I went to do my residency in orthopedic surgery at Johns Hopkins, and then did a sports medicine fellowship in Birmingham with Andrew Sports Medicine. And here's a picture of my co-fellows and Dr. Kane, my mentor. So I want to talk mainly about why sports injuries occur. I think if you can go on WebMD and you can search your symptoms and say you have anterior knee pain, they'll guide you down a path of what that generally might be. So it's good at diagnosing things, but we don't always understand the why behind it. And that's what I really want to focus on today. So for these guys, you know, it's maybe pretty obvious of why an injury occurred. They're running down the field going 22 miles per hour and they get hit in the knee. It's pretty obvious why that happened. But I want to get into that a little bit more and have a framework of why we experience sports and activity related injuries. So this is overall, if you think of it in this way, is that the reason that we get injured is because we have a force that's applied to a joint that exceeds the threshold of function for that particular joint or a body part. And if you think of this bridge, so this picture I took in Norway of this little bridge, and you think of normal person walks across it, there's no problem, the bridge works the way it should. But say that person brings a herd of sheep with them across the bridge. Well, then maybe in that case, the bridge starts to sag, or even it breaks, or maybe that the bridge is not maintained correctly, so it hasn't been used for a long time, and now it gets a lot of traffic, and the cable breaks, or even something catastrophic could happen. Say a boulder runs down here and knocks over the bridge. Well, then that would be a reason that why it would fail. So if you think of a joint like this bridge, all of those things same things still apply, that there's too much force that was applied to it, or it wasn't properly maintained. And so the threshold for it to break is lower. And that's the way that we look at injuries. And this was the model that was really we all follow. This was by Scott Dye, and he actually published on this. And this is what we call the envelope of function. So if you look at this line, you can either look at how much you're doing an activity or how strenuous that activity is. So say you could jump from 6 feet of height and you do it once, and you might be okay doing that. Or you walk for 10 minutes or 20 minutes and you're totally fine doing that. But if you were to jump from a height for 10 minutes over and over and over again, that may exceed that envelope of a function for your joint, and that just may be too much for your joint, and that's going to cause pain and disability. So this is the way we like to think about it, is that when you get outside of that envelope of function, that's when problems can occur. All right, so this is another thing I want to mention today, is that some things require surgery and some things require rehab, and sometimes a little bit of both. So these are the symbols. Whenever you see this symbol, this is going to be our rehab symbol, okay? And this is going to be the one for surgery when things that may require surgery, all right? So let's get into it, specific conditions. So patellofemoral pain syndrome. You may have experienced this where you feel pain over the front of your knee when you're increasing your activities. Say you just started running again and you start feeling pain there. So why does this happen and what is it? So these are some of the drawings, and if you came to see me in clinic, I might draw some of this out for you on a notepad. This is what the knee looks like. This is a femur, this is a tibia, and this is a patella here. And this is looking at it from the side. Well, your patella acts like a fulcrum and it allows you to bend your knee. But there's a ton of force that goes underneath your patella, up to 8 times your body weight at any point in time. So it's a lot of force. The other thing to consider is that the way that your patella is lined up, it runs over the front of the knee, and the things that attach to the top of the patella kind of want to pull it this direction. And that's just natural. That's the way it naturally is. So there's a tendency, if the muscles are not balanced around your knee, that it's going to pull the patella laterally like this. And this is what it looks like if you're kind of looking at it up through the middle of the knee, that your patella runs in this little groove like this. And if everything's not balanced right, you're going to pull it in outside of the groove, and it's going to bump up this part of the bone up against this part of the bone, and that will ultimately cause pain. So if your tracking is not correct underneath the patella, that's why you get this pain. So how do we fix it? Well, you really have to have a balance of the muscles around your knee. So here's your patella right here. A muscle of this medial part of the knee is a part that generally can be a little bit weaker than the muscle on the outside. So what we do is with therapy, we work on strengthening this medial side and this quad muscle. And generally that's enough to get you pain-free with this patellofemoral pain. And the next thing I want to talk about is IT band syndrome. So the IT band is this band of tissue that runs all the way from your hip all the way down below your knee. And generally people can have either hip pain or knee pain associated with this. This would be generally, we see it in runners or people, again, that are starting to increase their activities a little bit more quickly, and they can start to get this pain around the outside, that lateral part of their knee. So why does this happen? Well, this is your IT band. It connects up here and it connects down below here. So this is looking at it in the front. And you can see how it runs right over the lateral side of your knee. Now, what's interesting is when your knee is in flexion, the IT band runs behind the knee here. But when you straighten it, it runs right along the front of the knee here, okay? So you can imagine if you were to flex and extend the knee over and over and over again, this band of tissue is gonna rub right over top of that lateral part of the knee, and that's what causes pain. So what do we do for this? Again, therapy is very, very useful. So things like stretching, if you stretch that IT band, now it's not like a guitar string that's running over top of that bony part on the lateral part of the knee. Now it's a little more flexible and it moves smoothly over top of that area, and it makes it where it's not painful anymore. So mainly we can get this better with therapy. So what about ACL tears? Well, these are things that we normally see on the football field, on the soccer field, and they're more high energy injuries. Well, what is an ACL? So an ACL is a ligament that runs through the middle of the knee. And the main purpose of the ACL is to prevent this bone, the tibia, from going too far forward on the femur. And you see how the way it's aligned is that it's holding the tibia from going too far forward. Now, if you get hit or if you twist the knee in the wrong way, you can actually tear this ligament and then this will go forward. And if that's the case, and this is something that usually does require surgery. And so we would actually reconstruct that ligament doing a procedure where we do put scope in the knee and look through cameras, and then we can actually reconstruct that ligament to make it work correctly again. Another common injury is meniscus tears. So the meniscus is this bumper, and it basically it causes the stress from the bone here, all of the load from the bone here, to be dispersed among a larger surface area. You think if you don't have your meniscus, then all the pressure would be kind of right here, whereas with the meniscus now it's spread out into these areas. So sometimes when you get a meniscus tear, you may twist your knee getting out of the car and twist the knee, and you feel a little bit of a pop and you have swelling in the knee. That's a sign that you might have a meniscus tear. And it can look differently. In certain cases, you can get what's called a bucket handle tear, where it tears and it kind of comes into the joint like this, or a parrot beak tear where it kind of is shaped a little bit like that. And then, or you can have a radial tear where it comes into the area like this, or kind of a more degenerative tear. But the main thing with a meniscus tear is to have it evaluated. Sometimes we'll get an MRI of the knee for a meniscus tear to see what it looks like. And depending upon your symptoms, it may require surgery, or it may be something that we can get better within injections and physical therapy. So let's move on to shoulder. So you may have heard about rotator cuff or rotator cuff tears or rotator cuff problems. Well, what is a rotator cuff? The rotator cuff are these small muscles that run along the back and the front of your shoulder. They're not that big muscle, not the big deltoid muscle you see, on weightlifters and things, but it's the really small muscles that are underneath that. And the point of the rotator cuff, interestingly, is not to lift your shoulder or move your shoulder. The point of the rotator cuff is to hold the head. This is your humerus, your arm bone, sitting like this, to hold it up against the socket. Your shoulder is not like your hip. It's not constrained. It's not a true ball and socket joint. And we're made that way so that we can move your arm all like this. If it was a true ball and socket, we wouldn't be able to do that. So the rotator cuff, the point of it is to hold the ball in place so that the big muscle on the outside can rotate the arm. Well, what happens if your rotator cuff is not working correctly is that when this big muscle tries to move, it doesn't rotate, but it slides around, and it slides the bone here, slides up, and it pinches up against this other bone, and it causes problems and disability. So what do you do for rotator cuffs? Well, if it's something that the cuff is just weak and it's not working properly, then we can get you to do some exercises to work on strengthening those muscles, those rotator cuff muscles, so that the shoulder works properly again. If it's something that you have a tear or a true tear of the rotator cuff, then that's something that generally does require surgery for us to fix that back so that that rotator cuff can function correctly again. The last thing that I want to talk about is biceps tendon, proximal biceps tendinitis and tears, and then slap tears or labral tears of the shoulder. You may not know, but the biceps tendon actually in the arm, you think about your big biceps muscle, actually attaches up into the shoulder. And so it's got this really long tendon that comes all the way into the shoulder joint. And sometimes that can cause pain. So this is what it looks like. Your biceps tendon runs all the way up the arm, and then it attaches on this thing called your labrum. And the labrum surrounds the shoulder joint and allows it to kind of deepen that joint and allows the joint to be a little more stable. So this is what it looks like if you're kind of looking directly at the joint, is you've got this biceps tendon coming in, and then it connects onto the labrum that surrounds the shoulder joint like this. And normally it works fine. You don't have any problems, but sometimes if you pull on that biceps, say you're doing CrossFit and you're doing a bunch of the activities over and over and over again, over time, you can potentially pull this labrum off of the joint, and then that can cause a lot of pain, or you can get tears in the biceps tendon itself. So what do we do for it? Well, it really depends on what your symptoms are, how long it's been going on for, and what your level of function is. And again, if for this picture, perhaps his level of function requires that everything to be working exactly correctly every time. And so he may be one that we may need to do surgery on after we've done some therapy, whereas his colleagues, his classmates, they may just work out and they may not need to do a surgery on the shoulder, so they may be able to get away with therapy. And that's where we can come in, is we can work with you to understand what you do and to be able to guide you along the path of whether is surgery the correct thing that you need, or is it, or can we get this better with therapy, or a combination of both. So I hope that was helpful, just to give you a little understanding of the anatomy and why some of these injuries occur. It's a fun thing about doing sports medicine, as I get to cover a lot of other interesting events other than football and basketball, things like the rodeo. So this is my kids at the West Alabama rodeo. And unfortunately, we didn't have any major injuries that night. And then just kids, I know everybody likes to be active. So we're out here on the Billy Goat Trail. So we do get some of the injuries from there as well. So really happy to answer the questions at the end, and interested to see what kind of discussion we can have. John, you want to take it?
Yes, that was an outstanding presentation, Alec. So my name is John Thompson, or Dr. Thompson. I'm a orthopedic foot and ankle surgeon. I'm going to talk about, similar to Dr. Johnson, I'm going to talk about some common foot and ankle sports and overuse related injuries, with the focus on how to stay active and healthy and when to see your orthopedic foot and ankle surgeon. So I have no disclosures related to this talk, and I receive no compensation for any of the products that I do mention in this talk. So the injuries I'm going to discuss today, I'm going to start up a little higher in the leg. I'm going to start with Achilles tendinitis, talk about Achilles tendinosis, which sounds very similar, but it's a little bit different. Then we'll talk about Achilles tendon ruptures. Then I'll move down to the ankle itself, talking about ankle sprains and ankle fractures. And then finally, we'll finish with a common foot injury, plantar fasciitis. For each disorder, I'm going to talk a little bit or define what that disorder is, and then what you may experience. What does it feel like? Where does this injury occur relatively in the foot or ankle? Why does this potentially occur? And then what it looks like and if imaging is helpful, just to help guide you along the treatment course. And then finally, how to treat it. And we'll talk about both in certain times when non-surgical treatment is indicated and other times when surgical treatment is indicated. So I also have a couple poll questions here, and we'll have this running in the background again for you just to think about over the next slide or two. But the poll questions are, have you ever injured your foot or ankle acutely? Have you ever experienced nagging pain without an obvious injury in your foot or ankle? And then finally, if you do unfortunately injure your foot or ankle or have pain in your foot and ankle, what should you do? So while you think about that, I'll tell you just a little bit about myself. So I'm a fellowship-trained orthopedic foot and ankle surgeon, and I specialize in all types of orthopedic foot and ankle injuries and issues. I did my training for medical school at Johns Hopkins and also did my residency with Dr. Johnson at Johns Hopkins as well. And then I did my orthopedic foot and ankle fellowship at Union Memorial and also some time at Mercy Hospital, both in Baltimore, with Drs. Lou Schoen and Greg Guyton. So for this next section, I'm going to talk to you about Achilles tendon disorders. And again, these are common injuries in both the active individuals, but they can also occur even without athletic injury in the aging population. So Achilles tendinitis involves inflammation and some degeneration of the tendon substance and inflammation of the surrounding tissue, which is called the peritoneum. Pain is located in the back of the ankle, and it occurs during or even after activity, particularly with high impact activities like running or jumping when pushing off, a mechanism called plantar flexing the ankle or pushing your foot down. There may be some thickening of the tendon, and there could be some mild associated warmth or tenderness in that area. Pain occurs here because there is relatively little blood flow to the tendon in this region. Repetitive microtraumas that the body can normally heal accumulates over time, and this can lead to inflammation causing pain and some degeneration of the tendon, which causes some of the thickening that you might see, such as in this picture here. Calf tightness is associated with the injury, as lack of mobility can help to concentrate stresses in this particular region, leading to the accumulation of the injury. Imaging can sometimes be helpful in this scenario. X-rays, which in general for all my following disorders I talk about are the primary imaging modality to start with, can show some soft tissue swelling in the mid-substance of the Achilles, or where the Achilles tendon is thickest behind the ankle. An MRI can be indicated MRI can be helpful if indicated and can show some inflammation and thickening of the tendon. However, the majority of Achilles tendinitis can be successfully diagnosed and managed without advanced imaging. So treatment really just depends on how severe the disease is when you present. So if you are still able to do activity, but have some discomfort, then we will typically start with stretching. The stretches which are shown to the right are the following. First, you lean against a bed or a wall, whatever is convenient for you, and then you put your affected leg behind your body, such as in this picture. You keep your knee locked straight and your heel on the ground, and then you lean into the wall or the bed. You then hold this stretch for 10 to 20 seconds. As stretching improves over the following few weeks, you can then also incorporate some heel rises shown on the far right. What you do for this at home is you go to a bottom step or even a stack of books. You then will gently lower your heel down below the level of the stair or the book, and then slowly rise back up onto your toes above the level of the stair or book. And then again, repeat this 10 to 20 times. Both of these exercises can be performed a couple times a day, such as in the morning or night. And they also can either be performed by you at home or guided by a physical therapist if you prefer. If the pain is too significant to perform the activity, then the best treatment is actually just to help calm things down by immobilizing the ankle in one of those tall clunky cam boots. This works by minimizing the stretch and the strain in the Achilles that is required with walking and with daily activity. Resting the Achilles gives the body a chance to heal it. Typically, cam boots are used anywhere from between 2 to 6 weeks, just depending on the progression of how you feel. Once the Achilles feels sufficiently better, then we can begin these eccentric stretches that I talked about before. Finally, for persistent cases that do not respond with the above treatments after a few months, then surgery may be discussed. This entails cleaning up the tendon and then either repairing it or transferring a nearby tendon to help augment function. There also has been some discussion about injections or other percutaneous treatments, but in general, these are largely experimental and there are no solid long-term results available yet. So the next topic to talk about is insertional Achilles tendinosis, which is similar but a distinct pathology involving the Achilles tendon. This involves actually more degeneration to a greater extent than the tendinitis. And the body will actually deposit some calcium into the most degenerative segments, which is a process called calcification. These calcifications can secondarily cause pain due to the prominence behind the heel, such as in this picture, with shoe wear. So again, the pain is located behind the heel. It is worse with activity, but even can occur at rest afterwards. And then you may even notice a lump behind your heel in more severe cases. Like tendinitis, it is also associated with some tightness in the calf, as this can increase stresses from daily activity where the tendon inserts into the bone in this location. Patients with insertional tendinosis are generally a little bit older than those with just purely tendinitis, as I discussed last time. So for insertional tendinosis, x-rays are actually quite helpful here. In bad cases, we can see large calcifications, which is better known as bone spurs, and they can be seen as in this x-ray behind the heel. MRIs can also be helpful if we are discussing surgery, just to plan it, and particularly to see how degenerative the tendon is and where we need to do surgery. But in general, an MRI is not needed for initial assessment. Treatment is similar to that of Achilles tendinitis and really just depends again on how symptomatic you are. The size of the calcifications generally correlate with symptoms, but not always. With mild to moderate disease, we can certainly trial physical therapy and stretching with or without an initial period of immobilization in a cam boot. Unlike tendinitis, though, which does have a good chance of healing, the calcifications are unfortunately irreversible. Therefore, surgery is more frequently needed than with just purely tendinitis. The surgery itself would consist of removing the tendon, removing the calcifications and the bony prominences beyond the heel, and then reattaching the tendon. Sometimes we also have to transfer a nearby tendon, again, to augment the function. So next, I'm going to talk about our acute Achilles tendon ruptures. So an Achilles tendon rupture is a complete tear of the tendon in the mid-substance, or that region behind the ankle. With significant enough injury, a previously healthy tendon may tear, such as what Dr. Johnson was talking about when the force exceeds what the joint can handle. Other times, patients may actually have some persistent or nagging discomfort in this region before it tears, what we call prodromal symptoms. Patients oftentimes feel like somebody kicked them from behind in the back of their ankle, only to turn around and realize that no one is actually behind you. You also oftentimes experience significant pain immediately after this injury. Frequently, you may fall and have difficulty standing or walking afterwards. Although you can still plantar flex or point the foot down, it is usually very weak. So diagnosis is typically clinical. And advanced imaging is not necessary unless there is concern for a substantial amount of degeneration before the acute rupture. So treatment is actually highly debated in orthopedic literature, but in general, there have been a couple of key points here. First, studies have generally found that strength with plantar flexion or pushing the foot down is significantly better when it's fixed with surgery versus treating it without the surgery. And second, we have found that surgery may reduce the risk of re-rupture compared to non-operative management. Re-rupture is when you unfortunately tear the same tendon again, even after it's healed. Surgery is generally therefore indicated for younger and more active individuals, whereas non-operative management is recommended for older and less active individuals. Regardless of the treatment chosen though, a period of non-weight bearing and immobilization followed by early guided physical therapy is helpful to help maximize the body's ability to heal the tendon properly. So now we've talked about Achilles injuries. Now I'm going to talk a little bit about ankle injuries. Ankle sprains are one of the most common injuries in sports and in daily life. Many of you have likely experienced at least one ankle sprain already. A sprain is technically tearing of a ligament. Ligaments are strong structures that connect two bones at a joint. They allow for motion at the joint, but hold the bones in a close anatomical configuration to help maintain stability. Depending on the severity of the sprain, the ligament may experience only microscopic tears, or in the most extreme circumstances, may completely tear in half. There are many different ligaments in the ankle that may become sprained, but the most common ones are called the anterior talofibular ligament, or the ATFL, and the calcaneofibular ligament, or the CFL. These ligaments are located on the anterolateral and lateral aspect of the ankle, or better known as just the front and the outside parts of the ankle. Rolling the ankle is most commonly how these two particular ligaments are injured. You may complain of sudden pain and bearing weight, and also with ankle motion after injuring these. There may also be some rapid swelling and even some bruising on the front and outside part of the ankle. So in terms of imaging, x-rays are important here to help to differentiate between an ankle sprain and an ankle fracture, both of which can feel similar immediately after injury and can both be injured in a similar mechanism. MRI is actually not generally helpful immediately after injury, but for ankle sprains that do not improve after at least 1 to 2 months, MRIs can be helpful to assess for an underlying injury to the cartilage that unfortunately typically does not improve. Ankle sprains are almost universally treated with some form of immobilization, followed by graduated physical therapy focusing on motion. This is called proprioception, or helping to train your body to stabilize your ankle subconsciously. The majority of ankle sprains will improve on their own after a few weeks to a few months. In a small subset of patients, the ankle may permanently be less stable than it once was, and this can lead to recurrent and/or worsening ankle sprains in the future. This may require surgery to help stabilize the ankle to reduce future ankle sprains and also to help protect the cartilage. Occasionally, the cartilage in the ankle is injured at the time of the ankle sprain. This may lead to persistent pain that does not improve after that 1 to 2 month period. Should this occur, surgery may be needed to help clean up and potentially repair that cartilage injury. Now we're going to talk about ankle fractures, or a broken bone in the ankle, which involves breaking at least one of the bones around the ankle. Almost always this involves breaking the lateral malleolus, or the bone on the outside part of the ankle. Frequently, the medial malleolus, or the bone on the inside of the ankle, may either be broken or the strong ligament that stabilizes the inside of the part of the ankle, called the deltoid ligament, is completely torn, which functionally acts like a broken bone. This is one of the most common fractures in orthopedics requiring surgery. It can occur in both young active individuals, but also in older and even more sedentary people. Frequently, this involves rolling the ankle, which can result from a slip, fall, twist, or really any other mechanism. How the ankle breaks depends on what position the foot and ankle are in and what the force is applied. There are a few basic patterns to ankle fractures that help to categorize whether the ankle is unstable and therefore needs surgery. Stability to the ankle, in essence, is determined by the structures on the outside, the inside, and the back part of the ankle. And in general, if at least 2 of these 3 are injured or disrupted, then the ankle is deemed unstable. Regardless of how the ankle is injured, patients typically experience immediate pain and swelling over the next few days. There may also be some bruising under the skin. In really bad injuries, the skin may actually tear and the bone is exposed to the outside environment. Patients frequently are unable to put weight onto the affected ankle due to pain or instability. So x-rays here are crucial to diagnose a fracture. Typically, 3 different x-rays of the ankle are taken. Sometimes x-rays of the foot and or the leg are also needed to assess for other similar injuries. MRIs are not helpful since bones are seen better on x-rays than an MRI. A CT scan may be required though if the fracture is very complex. Treatment depends on whether the ankle is deemed unstable. Again, instability occurs when at least 2 of the 3 supporting structures around the ankle are injured. If only one structure is injured though, then the injury can usually be treated with just immobilization without the need for surgery. For unstable ankle fractures requiring surgery, most commonly this requires putting a plate and screws on the outside part of the ankle along the lateral malleolus. Screws may also be needed on the inside part of the ankle on the medial malleolus, and sometimes the back of the ankle also needs to be fixed. All the bones are carefully put back in their proper alignment before fixing with the plates and screws. Since bones start to heal after 1 to 2 weeks, it is important to fix these fractures after the injury to minimize the chance that the bones can be put back into the right place. Lastly, I'm going to talk about a common foot injury. So plantar fasciitis is a common injury as well. The plantar fascia is a strong tissue on the top, on the bottom of the foot. It helps to transfer energy from your strong calf muscles to the tips of your toes when you're walking, during normal gait, and during running and jumping. Given that it experiences such a high load during each step every day of your life, it is prone to inflammation and irritation. Plantar fasciitis is indeed a very common issue among many patients. Patients typically report pain when they first get out of the bed or the first few steps after prolonged sitting at a desk or in a car. Pain is located on the bottom of the heel, and it may radiate along the bottom of the foot towards the toes. As the foot warms up after a first few steps, pain typically will improve or even disappear. It may then worsen after prolonged use by the end of the day. The reason why pain occurs when first getting up is because the ankle normally flexes or points down at night. This allows the plantar fascia to relax and to tighten. Initial stance and the first few steps the following day or following morning will acutely stretch the fascia, which causes pain until it can fully relax again. Imaging is unnecessary to make the diagnosis, but can be helpful for chronic plantar fasciitis that does not improve after many months. Treatment is almost always non-operative, and surgery should only be an absolute last resort for this pathology. The vast majority of patients improve with a regimented stretching routine, whether that is self-directed or with the aid of a physical therapist. Stretching focuses on the calf muscles and the Achilles tendon and the plantar fascia itself. The first stretch is like the one I showed you before for Achilles problems, where you're leaning against a wall or bed. Again, put the affected foot behind your body, keep your knees straight and heel on the ground, and then lean into it. Hold this for 10 to 20 seconds. The other stretch involves actually crossing your affected leg on top of the other leg, and then pulling the toes back and pulling the ankle back at the same time. Again, hold this stretch for 10 to 20 seconds and do this a few times a day. Improvements are usually noted after a few weeks of persistent stretching. A night splint is helpful to help keep the plantar fascia under some stretch at night so that it does not relax too much. These can be bought online for around $20 to $25, so it's not too much. However, not everyone can tolerate wearing a brace at night though. Try to wear supportive shoes and even possibly some over-the-counter orthotics to help support your arch as well. This can help to reduce the stress and strain on an already inflamed plantar fascia. If pain isn't changed after many months of treatment, then injections and rarely surgery may be discussed. So with that, again, I'd like to finish up my part. Again, if you do feel a pop or hear a crack, have any nagging pain, please feel free to call my office to be evaluated by me. Both Dr. Johnson and I are located at our location in the Bethesda area on Rockledge Drive. So for any further information, again, you can visit hopkinsmedicine.org /ortho. For appointments in the DC region, again, call that number is 240-762-5100. And if any of you are located in any other locations out there, you can just call the general number for the entire Hopkins orthopedic system, and that is 443-997-2663. All right. Go to the last slide.
Last one. Oh, there we go.
Yep, great. So if you have a questions, go ahead and type the question into the Q&A box and then click send. These will all be anonymous. They will then be filtered to us, and we'll go through questions in more or less the order in which they're received. And we have about 25 minutes left, so we'll try to answer as many questions as we can, but we apologize if we don't get to every single question.
John, you want to start with that first one? I think you got an ankle question.
Oh yeah, let's see. So the question is, what about those of us who are dealing with ankle flare-ups from a previous fracture and I can't play Special Olympic sports because of it? So it's always a little tricky with a prior injury, particularly one that may have either healed fully but then developed some subsequent issues, or one where an injury where it just didn't quite get back to normal. Unfortunately, if you have a bad injury like an ankle break, it may never be that 18-year-old ankle that you once had. But again, our goal is to try to get you as functional and healthy as possible. So what could have happened with a prior ankle fracture is something unfortunately called post-traumatic arthritis. You may have heard of arthritis, or technically osteoarthritis, in hips or knees, which some of you may have even had hip or knee replacements for. In the ankle, for some reason that's not fully understood, primary arthritis, or just generalized wearing out of the ankle cartilage, is actually not that common, which is surprising given that the ankle is smaller than the hip or a knee. You would figure that a smaller joint will wear out faster. Instead, ankles typically get arthritis after a bad injury, such as a fracture. So it is possible that you are having, unfortunately, a flare-up of some arthritic type pain in the ankle with a prior ankle fracture.
All right, John, I'll jump on this next one.
Sure.
We'll skip to this kind of more general question.
Yeah.
Is rice really helpful for all sports injuries, or is it a myth? And I think that's a great question. And you could probably talk about this for a long time. Rice is rest, ice, compression, and elevation. And generally, it is helpful for most injuries. I think it depends on the severity of the injury. And it kind of goes back to a little bit about when I put up those symbols on what needs physical therapy and what needs surgery. Those things are all trying to help with inflammation and swelling. So if you put ice on, if you elevate the extremity, if you compress the extremity, and you rest it, then that inflammation generally is going to go down, and the swelling is going to go down, and absolutely it's going to help your pain, really, no matter what type of injury that you have. But is it going to be able to completely get rid of whatever the condition is? For something like and John, for an ankle sprain, or something like where you have Patellofemoral or something along those lines, where you have a little bit of inflammation that's going on, then generally it can be very helpful, and it can actually make things completely better. Whereas if, say, you had a meniscus tear or an ACL tear, while it would help your pain, it's not going to be the completely solve the problem. So it's a little bit of both. I think it is helpful, and we definitely recommend those things, but it's not always the final treatment.
Okay. I'm going to hop on another foot and ankle question here. Someone's mentioned that they unfortunately sprained their ankle at work and took some time off from CrossFit to try rice. About 2 months later, getting back into CrossFit and wearing an ankle brace, there would be some days when I had pain and others where it was fine. Why is that? And is something I just need to adjust to for life for now? So again, it's injuries can always be a little tricky in that anytime that you sounds like you sprain your ankle. If you did sprain your ankle, the ligaments, they don't quite heal with normal ligament tissue. They heal with some scar tissue. Sometimes that feels completely fine and you don't have any issues. Other times you can have some persistent or nagging pain afterwards. It just depends on the exact situation, but it may just be some residual sequela of the ankle sprain. These can take even a couple of months to get better. So unfortunately, we're all rearing to get back to our usual daily lives and activities, but sometimes our bodies just need us to take a little bit more time. Other things that we can do to help out is you can try wearing an over-the-counter ankle brace called an ankle stabilizing orthosis. These are the ankle braces that have straps that go across and around the ankle. This provides a little extra support that can be helpful, particularly as you're trying to get back into the activity. And whether you end up using the brace for full time whenever you're doing high level activities or just temporarily while you're continuing to heal up, it's just on a person to person basis.
All right. John, I think makes most sense. We're going to get to this question about the ball, pain in the ball and of the foot and toes. I will get to that one. I want to jump to this question first about can you speak about the success of surgical treatment for osteochondral lesions of the tibia? And that, it's interesting because that question could apply to the ankle or it could apply to the knee. And there's different thoughts on kind of the different joints, but overall, osteochondral lesion is where there's been damage to the cartilage, and the bone underneath that cartilage is also damaged. So it's like a little hole in the joint, and it really depends upon how big that hole is and where it's located. Areas where are kind of in the middle of the joint, where there's lots of good surrounding cartilage around it, generally do better. And these generally do better in younger patients who have a little more potential to heal. But the good thing is that this is an area that's advanced dramatically over even the last 10, 15 years. So where we have lots of different treatment options for treating osteochondral lesions. So if you choose the right option and you have the right pathology, then generally we have very good success in treating osteochondral lesions. John, I don't know if you want to talk about that on the tibial side.
For sure. Yeah, I realized I slightly misread the last question I answered because the ankle brace had already been tried. The other thing I just quickly want to mention also is trying some formal physical therapy because those proprioceptive exercises can also help to stabilize the ankle, and that may be enough to help get past that hump. But talking now about the osteochondral lesion, again, that's essentially just having like focal arthritis where the cartilage is worn out. It is certainly a tricky issue in foot and ankle. Most commonly, it's in the talus, or the bone is actually in the foot, but sometimes, rarely, it can occur on the tibia or the leg bone as well, on the leg bone side of the ankle joint. There are a couple different treatments out there. In general, they all do pretty well. But it's unfortunately not like the normal cartilage. Certainly, if it's painful enough, then it can be a substantial improvement. But in general, it can be a difficult injury to get back. Likely, we'll be able to get you back to activity again, but like many of these injuries, unfortunately, it's just not like your 18 or 20-year-old ankle.
John, do you want to talk about the pain in the ball of the foot and the toes?
Yeah, so we have another question asking, having pain in the ball and the toes of my foot, what could that be? So part of the thing that interests me so much in foot and ankle is that it's a very complex body part. A lot of tendons, a lot of ligaments, a lot of muscles, nerves, arteries, veins, everything going through a small space. So it's a little hard to tell exactly what that pain could be, but there's a couple things. You have little bones called sesamoids that are underneath the big toe. They function just like the kneecap or the patella in helping to strengthen the motion across that joint. This helps to strengthen your ability to bend the big toe down. So it could just be inflammation of the sesamoids there, or it could actually be a problem in the joint right above it called the first MTP joint, or your big toe ball of the foot. That either could be arthritic, or if you have a big deformity like a bunion, it could just be that the joint is not working properly. If it's the other toes or the rest of the ball of the foot along the lines of your lesser toes, then it could potentially be overload or something called transfer metatarsalgia, where it is just too much stress is occurring at that joint and is causing inflammation. Or it could also potentially be arthritic type pain, particularly if you had any prior injuries there. So it's always a little hard to tell, exactly what the cause of the pain is. Oh, do you want to talk about the the next question?
Yeah, I think this is a great question. So how can I determine whether I'm at risk of a serious injury, whether it be the knee, shoulder, elbow, etc.? And I think that's a really, really great question because I think it applies to everyone. And so how can we protect ourselves and how can we prevent severe injuries and how can we know when we're at risk? Um, I think it really, really depends upon, and we go back to that framework of how much stress you're putting on your joints and if those joints are ready for that stress. So if you're somebody who has not been doing a whole lot of activity and athletic activity, and then you want to try and to get into that, if you were to go into it too quickly, and so say you just go out and you run 1 or 2 miles and you haven't been running at all, well, that's going to put you at risk for an injury. If you haven't been doing much athletic activity and you were to get out on the soccer field and play soccer with your kids, or without kind of stretching, without warming up, and without having have done that recently, then that will put you at risk for an injury because the muscles around that joint are not stabilizing the joint the way they could be if you had been kind of keeping that joint and doing those things more frequently. So I think, and my mentor, Dr. Andrews, kind of the godfather of sports medicine, this has been his life. He's kind of reached his kind of life goal in sports medicine is talking about ways to prevent injuries and mainly preventing injuries in kids. And the main thing that we are figuring out is that these kids that play the same sport all year long, like baseball, for example, have a much higher risk of injury, and they're getting hurt and they're needing surgery at a much earlier ages. So this idea of diversifying and playing all kinds of different sports and not completely focusing on one sport or one joint throughout the entire year can be helpful. So cross training would kind of apply to the older individual population. So maybe you don't run every day or run every week, but you do some swimming and you do other activities, and that can help prevent injuries. But as long as you're keeping your body in shape and you're moving and progressing slowly into new activities, that's going to give you the best chance at preventing an overuse injury or a serious injury. And that kind of goes into the next question, or how can I treat an overuse injury? Well, it really depends upon what the type of injury is. If it was something like that patellofemoral pain syndrome or IT band syndrome, which are very common overuse injuries, or biceps tendinitis or things like that, generally some physical therapy to work on stretching, to work on strengthening those joints and stabilizing the joint can be very helpful to get that better. Sometimes it requires a little extra nudge from us. So we can do an injection of cortisone into the knee or a cortisone into the shoulder area to kind of start the process of getting the inflammation down and getting you back to what you like to do.
So I have a follow-up question here that is specifically about, I guess, the middle toe. So in general, it could still be a similar issue, something called transfer metatarsalgia. However, that's more common with the second toe than the third toe. If it's the third toe or any of the lesser toes, if there is a deformity of the toe where it seems to be cocking up like that, that could be something called a hammer toe, which is kind of some of an overuse injury where it's a chronic condition where the strong capsule tissue underneath the toe starts to wear out, which allows the toe to normally be like that. It starts to cock up and tighten. That can cause pain itself with just a deformity or with shoe wear. So if there is a deformity there, it could be a hammer toe itself. Otherwise, it's again, it's a little hard to tell, but it could be something like inflammation of the joint if the joint is arthritic, or a hammer toe would probably be the most common things I can think of. If there is shooting or radiating pain that tingles down from the ball of the foot into the toes themselves, though, that could potentially be something called a neuroma, which is just inflammation and scarring of the nerve that helps to provide sensation to the toes. The neuroma is actually it's at risk for developing that area just because of the general anatomy. And over time, that can cause a painful neuroma, which causes that shock-like tingling pain into the toes.
I really like this next question, John. And I'm going to probably rely on you too for some of the literature, but am I at more risk of an injury in cold weather? Now, I know the Gestalt is, and I would just say that, yes, you are, but I don't know the numbers on that. And I have to, that's interesting. I'm going to have to look that up in the literature and see if there's a specific study that has looked at it. But the thought is that you potentially would be because in that colder weather, you may not have warmed up the joint as much. Everything is a little bit tighter. Your ligaments are less um, responsive to that stress, and so there's thought is that could put you at maybe a little bit higher risk of injury with that. I don't know. What are your thoughts on that, John? Do you think you're at a higher risk of injury
I
when in
agree.
cold
I
weather?
think it's similar even to what I was talking about with Achilles tendonitis and tendinosis, or even plantar fascia, where you have some tightness underlying. Again, it's the whole concept of kind of a length tension relationship that the body naturally or normally has with the muscles and tendons across a joint. And if that balance is off, whereas the muscles and or the tendons are tighter than they should be, then that means that you don't have that length tension relationship, and that can help to concentrate stresses, which the tendon is or muscle is not used to having, and that can quickly lead to an accumulation of too much stress and damage, which can result in pain or frank injury, such as a strain or a sprain or a tear. So I do agree that you may be at an increased risk in colder weather for some of these injuries, and so that's why it's even more important to properly warm up. Get a good stretch in, do a quick warm up run, or get the heart rate up and the blood flowing, and stretch out before and even afterwards, just to help reduce the risk of an injury. The other thing I can add in just for foot and ankle specific kind of overused injuries and preventative measures is really look at your shoe wear and your footwear. Many times patients may come in and complain of some foot or ankle pain or even knee pain with prolonged running, for instance, or walking, and then you take a look at the shoes and they're 2, 3, 4 years old and they're wearing out. Shoes definitely have a finite lifespan in them. And they will start to wear out after 6 to 12 months. And so one of the first things you can do if you're having pain, or alternatively if you want to help reduce the risk of developing pain or injury, is just to have change your shoe wear every 6 to 12 months, and even more so to have supportive tennis shoes as opposed to flimsy flat shoes. Or even if you're going barefoot in the house, that can be a lot of pain or stress. And wearing, a supportive pair of shoes or slippers in the house can be helpful as well.
We got a question. How can I reduce the stress in my throwing arm or kicking leg? I think it's all comes down to mechanics, and all comes down to making sure in the throwing arm, for example, we talked about that rotator cuff, and if the rotator cuff is fatigued or not working correctly, then it's going to put you at higher risk of injury. And so I think never throwing fatigued, and this is what the pitchers do. They limit their pitch count, and pitchers don't work out their upper body during the season. And they're working on those smaller muscles, your rotator cuff muscles, and we're doing band work and things like that throughout the season. It's not those big muscles that they're working on. So I think that's probably the biggest thing, is never do anything when you're fatigued. You don't want to go work out and do a big workout and then go out and try and throw in a game, or go kick, in a game as well. So I think that would be the biggest thing, is to make sure that your body's not too fatigued when you're trying to do that, and just make sure that you're having proper mechanics. So there are therapists that you can see, athletic trainers you can see, and then they have specialized services where you can go, if you're having an issue and you think it may be related to your mechanics, that you can go be evaluated for on your throwing motion or kicking motion and things like that.
Yeah, one other thing just to add in with that is the sort of distinction or delineation between soreness and pain. If you're having a little bit of soreness, it's okay to push through that, particularly in a rehab setting or a post-operative setting where you're trying to regain that function again. For instance, with the question earlier about the ankle sprain, if you're having a little bit of soreness, as you are increasing your activity, then that's okay. But if you're having a lot of discomfort, even frank pain, that's really your body's signal to you that you need to back off and give your body more chance to heal, simply because pain is sort of one of the only ways your joint or your muscle or your tendon or ligament can let you know that, hey, I'm not 100% yet. You can't push me through the grinder yet that I normally am used to. And so you just have to listen to your body. And it's not about being a go-getter or pushing through pain is the old adage. It's really important to listen to your body, and it'll tell you whether or not that you can proceed and continue, or alternatively, if you need to take a step back and give it a little bit more time to heal up.
We have a question, why is it some people who have a tear in the rotator cuff, but they don't always need surgery? And that's a really, really good question. And it really kind of depends upon the age of the patient, how bad the symptoms are, and then what the tear looks like. If it's a full thickness tear, meaning going all the way through the tendon, then generally that's something that we would operate on in most cases, because there's a fear that that tear would propagate and get larger over time. And studies have shown that. If that tear gets larger over time and the shoulder's not functioning correctly, it can lead to arthritis down the road. So those are the ones where we generally will operate on. If you get an MRI, and a lot of times on the MRI, it'll say, oh, there's partial tearing of the tendon or tendinosis of the tendon, rotator cuff, and things like that. Those are the things that we're generally more comfortable trying rehab for, trying injections for. And generally those things can get better with time and therapy. So it really it depends upon the morphology of the tear and then the particular patient.
Oh, let's see. There's another question here asking how important is massage and recovery. And Alec, I think that's a great question. I'll definitely get your thought into this too. I think it certainly can help. There is some, I think, evidence showing that direct pressure massage can help to increase blood flow to the tissue. Increased blood flow can help provide more nutrients and help get rid of some of the waste products that is natural with any sort of physical exertion. And so I do think there is evidence to support that, whether that's your own massage or getting a physical therapist or professional to massage. But obviously it might not be practical to get the luxury treatment at a nice spa after every single time you're working out. So you just have to find the right balance for you. Alec, what are your thoughts?
Yeah, no, I think that's great. I think massage is fantastic, and a lot of times when we have injuries, say you have a rotator cuff problem, or you have a biceps tendon problem, you're going to feel, a lot of times you'll feel pain that's referred from that, and pain. You have all the muscles that attach from your neck to your shoulder blade, and they get tense and they can get painful and everything because the rest of the shoulder's not functioning correctly. So in order to try and get some of that better, massage is fantastic for that. Massage can also be fantastic in the lower leg. I think it goes along with all of the treatments go together. So what we do from a surgical standpoint, what the physical therapist does with either joint manipulation and strengthening, and then things like massage to work on those areas that are specifically the muscle itself, to kind of de-stress that muscle and give pain relief. So I think it's a collaborative approach. And fortunately, we have lots of colleagues in all these different areas that can help us to try and get you better.
I see another one. Should I apply heat or cold to a muscle injury? It depends on what the timing of the injury. In general, after any acute injury or after, particularly after a surgery, for instance, there is a general tendency for the body to swell. That's just a natural reaction to help immobilize that area, to help provide additional nutrients to help heal things. The problem is that sometimes the body swells too much, and that can cause pain, that can cause some tingling, and in very severe and very rare circumstances, that can be a very concerning situation. And so the question then draws back to icing versus heat. Ice in general is better after an acute injury or after, early after a surgery, because it helps to diminish the inflammation and the swelling. However, if this is a chronic lingering issue where there no longer is that acute inflammatory phase after the injury or surgery, which is usually the first couple of weeks or so, then heat actually can be helpful to help warm up that muscle or that tendon, to help stretch it out to get ready to go, such as what we're talking about with the cold weather activity and making sure that you're ready to go. In general, after the activity, icing is usually better to help calm down that inflammatory response. But again, in that chronic nagging situation, the heat may be helpful to get the muscle warmed up to go. Alec, what are your thoughts?
No, I agree with that completely. I think I like ice to reduce inflammation, to reduce pain, to reduce swelling, generally acutely. I think heat is really good when you're trying to stretch. And so I'll talk to your therapist about, say you have a frozen shoulder, a condition we didn't necessarily talk about today, but or decreased range of motion of your shoulder. Then I'd like to talk to your therapist to have them heat up the shoulder beforehand, before they stretch and do the exercises, and then they'll put the ice on at the end to kind of calm things down. We have our last question, and it says, what is the difference between a shoulder separation and a shoulder dislocation? And I'm going to click back, if I can, to a picture of the shoulder real quick. All right, so a shoulder dislocation, a shoulder separation is a separation of this joint here. So this is where your collarbone attaches to the scapular or your shoulder blade. And it's this bone, this area right here. And what happens, you land directly on the shoulder and it pops there's some little bit of ligaments that live right here, and it pops those ligaments. And then the clavicle wants to go this way and the rest of the shoulder wants to go this way. So that's a shoulder separation. A lot of times that can be treated non-operatively, depending on how bad it is. But we do operate on that from time to time. A shoulder dislocation is where you actually, this part, the ball and the part of the shoulder pops out of joint. That generally is a more severe injury. And depending on your age and how many times it's come out of place and everything, we may or may not operate on that. But that's a really, really great question. And we get that a lot, of the kind of confusion between the two of them. All
so
right.
I think that might be it for our time. So we just want to thank everyone for tuning in to participate in this webinar with us. We really enjoyed speaking with you about our passions and our specialties. As Dr. Johnson mentioned earlier about the kind of the holistic or team approach with the massaging, we are part of the team of trying to help you feel better. It's a combination of us and the nurses and the physical therapists and other specialists out there as well. And so it would be a pleasure to help take care of, help you out and help you with any of the injuries or nagging pains you're having along the way, and to help make sure you stay active and healthy for a very long time.
Thanks, John. Yeah, thank you.
Yeah, thank you.